Okay, well, I think I'm going to go ahead and get started. And then I'm sure we will have some additional folks joining as we go along. Thank you all so much for taking the time to join us this afternoon. We're so happy to be here for the first of this learning community. My name is Elaine Chian. For those of you that I haven't met before, I am Special Assistant to the Executive Director here at the National Academy for State Health Policy. And I'm joined by two of my colleagues. So Ella, do you want to introduce yourself first?
Yeah, hi everyone. I'm Ella Roth and I'm a policy associate at NASHP on our behavioral population and public health team, and have worked on our health and housing project for about 2.5 years now. It's great to see you all and thanks for joining.
Thanks, Ella. And Robin?
Hi, I'm Robin Wagner. I am retired from the Louisiana Department of Health, where I was a leader in their Office of Aging and Adult Services, and was involved in the planning and implementation of Louisiana's statewide permanent supportive housing program. I'm now working as an independent consultant, and one of the roles in which I do that is with the National Academy for State Health Policy's Health and Housing Institute.
Thanks, Robin. And unfortunately, we don't have time for everyone on the line to do introductions, but if you want to drop your name and the state that you're representing in the chat, that would be great so that we can start to get to know one another. And next slide, Ella. So if you're not familiar with NASHP, we are a nonpartisan organization that's led by a 60-person academy of state health policymakers. So we really are of, by, and for state health policymakers. We work with both the executive and legislative branches and policymakers from a variety of health and human services agencies. For the last 7 years or so, NASHP has hosted 2 rounds of a Health and Housing Institute, which provides technical assistance to a small group of states working on bringing together the health and housing sectors to assist individuals access safe and affordable housing. And we're really excited to take all that we've learned through the Health and Housing Institute and the connections that we've made through that project to a broader group by hosting this learning community. So that's part of what we're hoping to do here. And I would be remiss not to thank the Health Resources and Services Administration, or HRSA, who is funding the Health and Housing Institute, as well as this learning community as well. And next slide. So as I said, we are so excited to have you all here today. This is one of our favorite things to talk about, and we're so glad that so many of you want to talk about it as well. This will be the first meeting of the state-only health and housing learning community. We really are recognizing that this is a unique moment with historic interest in the social drivers of health at the state and federal levels, including through the recently approved Section 1115 demonstration waivers and additional guidance under Medicaid, and unprecedented coordination across HHS and HUD to support states in doing this work. And we know that you all at the state level have a real opportunity to advance change right now. And we also know how hard this work is. So we want to make sure that we're here for you to support you along the way. These meetings, we hope, will serve as a platform for you to learn from national experts and from one another's experiences. So we will be asking for your participation throughout these meetings. This space is for you, so we encourage you to bring your questions and your lessons learned so that others can learn along with you. And we will give you an opportunity to do that in just a couple of minutes. Today is going to be an introduction to health and housing strategies at the state level. And in future meetings, we will dive a little bit deeper into the weeds of some specific topics, many of which you all actually communicated to us as things that would be helpful for you. So some of those topics may include thinking more in depth about partnerships across the health and housing sectors, priority populations, data sharing and integration, financing approaches, and how to support providers. And we will be flexible and shift as needed based on what comes up in these conversations and what we're hearing from you. And as you'll see, some of these will be tailored for you all to bring in your peers from sister agencies as well, so that we really are driving those partnerships and interagency work. And this learning community will be happening in tandem with the 3rd round of the Health and Housing Institute. Applications for that opportunity close on February 13th. And I will mention that we are aligning with the Federal Housing and Services Accelerator Program for the Health and Housing Institute. So please just reach out to us if you have any questions about the application or about participation in that project. And next slide. So since we do want to foster this as a real learning community and want you all to feel comfortable speaking openly with one another, this is a state-only space, with the exception of our partners at the Health Resources and Services Administration, who, as I mentioned, are generously funding this work. If anyone is here who is not with state government currently or one of our partners at HRSA, we do ask you just to drop off the Zoom at this time. And we will be recording these sessions and posting the presentation portions only for others to learn from. We will not be posting or publicly reporting out on any of the discussion portions. So anything that you say in these meetings will be treated as closed door and off the record. We will be bringing content and expertise, but we also need to hear from you all to share your questions, your lessons learned, and really just ensure that we're shaping these meetings to be as helpful to you as possible. So please do put things in the chat as we go along, or raise your hand to join the conversation. And we really encourage you to just take full advantage of this learning community and getting to know your peers in other states who are trying to accomplish similar things. We will plan on meeting every other month, and we will establish a listserv for communication in between meetings. So we hope that you all will take advantage of that as well. All right, well, next slide, please, Ella. Okay, so as I mentioned, we are seeing historic interest in access to housing and experiencing homelessness as a key social driver of health outcomes. And we know that being without a stable home is detrimental to one's overall health and well-being. And I'm going to let Robin talk more about permanent supportive housing in a bit, but I did want to introduce it as an evidence-based practice that states have focused on to address housing as a social driver of health. And part of the reason that they've gravitated towards this approach is because of the evaluations and the evidence of impact that we have. So supportive housing has been shown to improve housing stability and other social outcomes, such as employment and school attendance. It's been shown to improve physical and behavioral health outcomes, such as improved self-reported health and well-being, reduced substance use, reduced utilization of inpatient and emergency department services, and improvements in receiving care in community settings. And there's also evidence of cost effectiveness. The exact extent to which the reductions in healthcare costs fully offset the cost of housing does continue to be a subject of debate, but we have heard states and seen states report savings to public institutions through reductions in utilization of costly services, as well as through reductions in costs through social services and corrections as well. And health and housing approaches support broader state health policy goals as well, including prioritizing getting effective services to members with high needs, who also tend to be the most costly individuals. So that's often folks with serious mental illness and substance use disorders, those experiencing homelessness, and those who may have other chronic conditions. It also aligns with renewed priorities on reducing disparities and promoting equity, pursuing whole person and integrated care, and deinstitutionalization and transitions from inpatient or institutionalized levels of care. And next slide. So we do know the health and housing sectors have a long history of being siloed across the funding and resources, the programs and policy, and the data. And in addition, there are housing and workforce shortages that are complicating this work right now. And successful health and housing initiatives necessitate bringing resources together to support the housing itself, the cost of operating a housing program, and the supportive services that individuals need. So while this is difficult, and we recognize that there are real barriers in place, there are state examples of doing this on a broad scale, and or targeting one or a couple of these barriers. And that's what we hope to be able to bring to you today and throughout this learning community series is some of those examples. Next slide. So as I mentioned, there are effective examples in states, and there are several things that those approaches have in common. So we've found that successful health and housing approaches include first, deep and robust partnerships between housing and health. And those partnerships are really the foundation of success. In some cases, they are formalized through coordinating bodies such as interagency councils on housing or homelessness, like we just heard about. Through memorandums of understanding or other agreements. And then in other cases, they are more informal. Second, these approaches are data-driven to identify target populations and the services that those individuals need. And they prioritize data sharing in order to implement those programs and to drive evaluations. And I will note that data sharing and integration has been a priority and a real challenge for essentially every state that we've worked with in the Health and Housing Institute so far. Third, these approaches implement and incentivize evidence-based approaches like permanent supportive housing and Housing First. Fourth, they develop sustainable funding for supportive services. And Robin's going to talk a little bit more about what those services might include. But Medicaid benefits are one source of funding, and successful programs also identify other sources of funding that can fill in some of those gaps where Medicaid cannot cover. And Medicaid is an important resource for doing this work, but it's not the only one. And we will go more in depth into a conversation of Medicaid and other financing options in a future session. And then fifth, successful health and housing programs increase access to housing itself as well. So this is both the bricks and mortar, and we do know that there is a severe housing shortage in much of the country right now. And also the resources, which would include vouchers and rental assistance, so that individuals can access that housing. And then finally, successful programs really demonstrate health outcomes and reduce costs so that they're driving reinvestment and buy-in for continued work in this space in the state. So before I move on, let me pause here and see if there's any initial questions. Can feel free to put them in the chat or raise your hand or just come off mute. And if not, then I will pass it over to Robin. And please do, as questions pop up, feel free to just put them right in the chat and we'll make sure we get to them.
Okay, thanks, Elaine. And first of all, I'm getting over a head cold, so apologies if I have to dab my nose or grab a sip of water as I'm going through this, but I'm really glad to be here today and happy for your participation. So I am going to focus on permanent supportive housing. As Elaine said, it's not everything that there is in the field of health and housing, but it's an important strategy and an evidence-based one. And so typically permanent supportive housing has been targeted to certain priority populations, such as people with disabilities, and that includes a wide range of disabilities, including chronic conditions for HIV. Since we have somebody participating from a Ryan White program, I wanted to mention that specifically. Certainly to people who are homeless or at risk of homelessness, people who are complex care or high cost to Medicaid and or other service systems have been identified and called out in particular as potential populations to be served by permanent supportive housing. And then another category, people at risk for housing instability, including pregnant people, high-risk families, youth aging out of foster care, persons re-entering from jails and prisons, and older adults, both transitioning from institutions and sometimes targeted for purposes of aging in place. Let's go on to the next slide. Well, you know what? Actually, let's go back. I just want to see for you all on the phone, if there's anyone that an important population, target population that you feel like we're missing here, please put that in the chat box. We'd be interested in sort of looking at that. Let's go on to the next slide now. Typically, the goals include things such as reducing homelessness, improving health outcomes, saving the state money, which is sometimes why those high-cost, high-need individuals are targeted. But even where you may not see huge savings in cost to Medicaid or other healthcare systems or other service systems, you can also see improvements in patterns of healthcare utilization. I'll use Louisiana as an example of that. We did see some modest savings from our permanent supportive housing program, but what we also saw were significant reductions in emergency room utilization, inpatient utilization, while also seeing an increase in behavioral health and primary care services, which is the kind of a pattern that you would want to see in the delivery of healthcare. It's also important that permanent supportive housing or supportive housing can improve other life outcomes for people, such as improving income or income stability. In Louisiana, that was one of our measures. It was done by connecting people to benefits that they were entitled to or assisting them with employment. Providing families with the stability to see improved school attendance and improved opportunities for employment. So all of these can be significant goals. Let's move on to the next slide. So when we say permanent supportive housing, what are we talking about? Really kind of combines two key things: affordable rental housing and then voluntary flexible tenancy supports. Those two things together, the housing and the services, are what create permanent supportive housing. And we have an emphasis on decent, safe, and affordable community housing that provides occupants with the rights of tenancy under landlord-tenant law and are linked to voluntary flexible services. And I'll be talking a little bit more. I want to be careful that we understand what we mean when we say voluntary. So let's move on to the next slide, which deals with our principles here. So the first principle of permanent supportive housing, I'll catch up in my notes, is that it is housing first. And what do we mean by housing first? What we mean is that people are housed without necessarily accepting services or sobriety or compliance with treatment or seeking employment or any of those kinds of things, that they are housed without necessarily accepting services and those other conditions. Now, I want to be very clear that housing first does not mean that there are no services available. It is very important in the evidence-based permanent supportive housing program that services be available and that there is a consistent and ongoing effort to engage the individual, the tenant, in services. And so certainly what we've seen again in Louisiana is that most people accept services or accept the services that they feel comfortable accepting initially, and that may change over time, but the effort to engage them in services is proactive and ongoing. So that wanted to make that clear. Another principle is that there's choice, that it's not just, we're putting you into this unit and you don't have much say in it, take it or leave it. But that people actually, their choices, their preferences about where to live and what kind of housing to accept are respected. Again, in Louisiana's program, people get at least 3 choices of unit and their first go on the waiting list for our program. Affordability. What do we mean by affordability? Typically, no more than 30% of income is spent on rent and utilities for affordable housing. Quality means that it's safe, decent, and affordable. I will give a very concrete example of this. Louisiana makes heavy use of scattered site housing in multifamily apartment buildings. Those apartment buildings tend to be mixed income, so you have people at very high levels of income renting places at market rates. You have people at more modest levels of income renting at lower rates. But the housing for the people in our permanent supportive housing program looks like the housing that anybody else in that apartment building who is renting, their units look the same. There's not any kind of lesser unit or a lesser section of the housing development that is set aside for permanent supportive housing. Consumer control of housing. What this means is that the consumer is the tenant. And so, we'll be talking a little bit about models, but what I would point out here that as an evidence-based practice, typically the service provider is not going to be the provider or the owner of the housing, that it's the consumer that has the rights of tenant under the evidence-based model. I already mentioned that housing is not contingent upon accepting services, but there's a continuous effort to build trust and engage. And then in terms of normal and community integrated housing settings being an important aspect of this, we're going to do a deeper dive into that in the next slide. So let's go to that and look at some of our models on the housing side for permanent supportive housing. So there are kind of three models that you see in a typical permanent supportive housing program. One is that units are scattered site. And a lot of times you accomplish that scattered site model by having individual tenant-based rental assistance. That is a voucher. Sometimes it's a state-funded rental subsidy that the individual, with the assistance of their service provider, can use to go out and find their own unit in the community. Another approach to scattered site, it's sometimes called cluster, but I don't entirely like that terminology. But another approach to scattered site, and this is something that, again, Louisiana used heavily, is to have units that are set aside as permanent supportive housing within a larger multifamily housing complex. I like to be careful about the use of the term cluster because, as I stated earlier, it's not as though you want to have one section of a building that's devoted to permanent supportive housing. You would want those units to be scattered throughout the development. And then finally, we do see single site permanent supportive housing where all or the vast majority of the units are permanent supportive housing for some target population, as we discussed in the earlier slide. And oftentimes with this kind of site, you see services actually on site. So I'm going to take a moment in just a sec to talk about the pros and cons and to get your thoughts on these. But I do want to clarify that what is not permanent supportive housing are group homes, personal care homes, and I know these go by different names in different states, but they're really places where there is ongoing supervision, and usually the property is owned by the service provider. Assisted living is not permanent supportive housing, neither is short-term transitional housing. And really, most models of recovery housing wouldn't fall under this rubric either. So I'm going to pause for a moment and first of all, share with you some of my biases, but then hear from you all about the merits of the different approaches. So I certainly do lean towards scattered site arrangements where the owner and the provider of the housing is not the same as the provider of the services. In Louisiana's program, even though we make some use of sites that are 100% for people who've transitioned out of homelessness, and those places do have some services on site, we have a Medicaid service provider, tenancy service provider that is separate and apart from that setting, so that they can be an advocate for the individual and also move with that individual if they leave and go to some other housing arrangement. But there's some arguments to be made on both sides of the equation around scale, around using what you have in your community, using your existing provider base, and using members of your continuum of care for the homeless who have a lot of experience and success in providing permanent supportive housing. So I want to hit pause right now and see whether there are any reactions to this issue of, what permanent supportive housing with the housing piece of it looks like. Thoughts or reactions? And is there anything that I need to go back and clarify at this point? Okay, I see we have a response in the chat about what does it look like in rural areas, and that is really a great point. And rural areas are a huge challenge, not just in terms of housing, but also in terms of services. How do you get the services out to rural areas? I will tell you that some of the approaches, like using multifamily housing as your base, are not as effective in rural areas. I will just tell you that from Louisiana's experience, we've had better luck using tenant-based vouchers to help people find housing in those kind of areas. And we've been fortunate to have a small quantity of state-funded rental subsidies that can be used in that way as well. But I think we should bookmark this as perhaps a session for the future, Elaine, I'm thinking, where we can bring on some folks who have specifically focused on that area to do services in rural areas. That's a great point. But I think it tends to look more scattered site and tenant-based in general. Okay, other questions or points? Okay, well, let's move on to the services piece of this. So we talked about one piece of this being affordable, and really that means deeply affordable, 30% of income for housing and utilities, which means that on the housing side, you have to have the resources to get rents down to zero sometimes for individuals who come into programs with zero income. But the other piece of it is the services piece of it. And as Elaine pointed out, Medicaid is a huge, I even want to say potentially central player in building the services piece of your permanent supportive housing program, but it's not the sole and only. And in future sessions, we'll talk about how to stream in, how to braid in other funding streams for the services, including funding streams like Ryan White, community development block grants, behavioral health funds, etc. But what do our basic services look like? Well, tenancy supports is the core service within permanent supportive housing, and we generally talk about there being two phases in providing tenancy supports to individuals. That first phase is pre-tenancy, where you are engaged in outreach and building trust and talking to the person, trying to find out what their housing goals are, and doing what you can to engage them with services and help them with getting into your permanent supportive housing program or arrangement. To move into tenancy, that means helping them secure identification and other documents that are needed, not just for housing applications, but to apply for rental subsidies and to apply for other services that they might need to have a successful tenancy within permanent supportive housing. That means applying for Medicaid. That may mean applying for food support and other kinds of services as well. Identifying resources to cover startup expenses, moving costs, and one-time expenses. So paying arrears on previous unmet utility bills, helping to make deposits, purchasing initial things that are needed to furnish an apartment, actually moving the person into the apartment. Landlord engagement and relationships are important. We've had staff in Louisiana whose role has really been to develop those relationships and that level of trust with landlords, but this is a very critical role for a tenancy supports provider. And then assistance with the move-in itself when the time rolls around for that. Once the person is in housing, then you move on to tenancy sustaining services, which would include goal setting and planning. And that doesn't just mean goal setting around housing. It's now that you are in the community, what are your goals within this community? What additional steps would you want to take? But an important component of this initial plan is eviction prevention and crisis planning. You help the person familiarize themselves with the neighborhood and how to get to services and how to use transportation. You teach and support skills for successful tenancy. So part of that is tenants' rights education, but it may also be how to keep the apartment clean, how to get along with your neighbors, how to access the services you need to be successful in the tenancy. An ongoing task of maintaining relationships with landlords and property managers. Ongoing assistance with benefit access and service authorizations, including keeping the tenancy support services and the rental assistance current. And then it's very important to be able to flex the type, intensity, frequency, and duration of services based upon needs and preferences. And so you have very high utilization when people are first transitioning into housing. Once stabilized, you may see utilization of services drop down a bit, but if there's a crisis or you have to go into eviction prevention mode, then you might see an intensification. So it's important to have the flexibility to be able to pull services back when the person doesn't need them as much, but to quickly be able to pump up the services when the need arises. Okay, I think we can move on to the next slide. In addition to those core tenancy support services, there are some other services that have found to be critical to maintaining people successfully in tenancies, especially if you're targeting people with disabilities, with chronic healthcare needs, with complex care needs, substance use disorders, behavioral health disorders, et cetera. So home accessibility, so being able to do modifications to the home to make it accessible for people who have mobility impairments, remediation of the home, to make it healthier and safer, environmental modifications for the same kinds of purposes. Assisted technology and DME can be very important, durable medical equipment. Personal care services to help people address their ADLs and IADLs. Depending on your service models, you may be addressing some IADLs through your tenancy support service. You may or may not. That's a decision that has to be made about what you're covering under tenancy supports. But people will oftentimes need those IADL assistances with budgeting, with managing their finances, paying bills, et cetera. Additional health and behavioral health services are critical. So your behavioral health agency is an absolutely critical component. I will say that when you're talking about a permanent supportive housing program that targets people with disabilities, you are often talking about people who have multiple chronic conditions, oftentimes a physical disability or medical need along with a behavioral health issue. And additional social services such as for food, childcare, employment, et cetera. Can move on to the next slide. So I hope that gives a sense, a very basic sense of the services. And I'm sorry, I'm going to go back to that last because we got a very good point in the chat box here. So what do we mean by ADLs and IADLs? ADLs stand for activities of daily living. They are core things that we need to do for survival, such as feed ourselves, toilet, move from bed to standing, et cetera. So this involves very hands-on physical assistance for persons who need ADL assistance. IADLs, by contrast, are what we call instrumental activities of daily living. They don't require hands-on care, but they are important aspects of assistance such as shopping, house cleaning, helping with finances. Others who can help me here throw some other examples of ADLs and IADLs into the box, but instrumental activities of daily living and activities of daily living are what the terms mean, or what those acronyms stand for. Okay. So again, I hope that gives some basics. We can go deeper into each of these components, and we will. We'll be looking for your feedback on this shortly. As Elaine pointed out, putting this together can be complex. I'm not going to spend a lot of time on this slide. We have a bunch of acronyms in the top row of the slide for the federal agencies. I think we need to resend this with maybe each of those acronyms spelled out. But these are federal agencies that at some level are involved with funding either the housing piece of things or the services piece of things, or sometimes both. At the state level, we've spelled out who some of the critical partners are on both the housing side and on the services side. At the local level, in addition to those state agencies, you might be dealing with a managed care company or program. You might be dealing with your regional or county level health entity, behavioral health entity. Continuums of care for the homeless are an extremely important partner, and so are public housing authorities, sometimes referred to as public housing agencies. They have housing, they have rental assistance that's tenant-based. They have a lot of resources that can be very important to access. And they're also serving the same low-income groups that we oftentimes want to target with permanent supportive housing. And then we have our providers, and we've got some of the categories of service provision that need to be thought about when you're talking about permanent supportive housing. But let's break it down if we go on to the next slide into some of the most immediate. If you all are state level participants, I just want to point out your housing partners in this endeavor at the state level are typically the following. Your state housing finance agency, every state has one. Sometimes they are a little known to folks in healthcare, but they are very important because they are the major source for the development of low-income housing through the low-income housing tax credit, which is a federal program that has capital for building housing. So a very, very important program. And state housing finance agencies oftentimes, I would almost say always, have additional funds that are used to help make housing affordable. Public housing authorities and agencies that we just mentioned, also a very important partner. Sometimes you have many, many of these in a state. Sometimes you have a state level public housing authority that can also work with. But your large public housing authorities, they have housing, they have capital funds, they have tenant-based rental assistance. They are potentially an important partner. Then you have state and local offices of housing or community development who handle community development block grant dollars. These are dollars that also come from the federal housing and urban development, but they are very flexible dollars that can be used as gap funding. If you're financing the building of affordable housing, they can be used for rental assistance. They can be used in a lot of different ways. And finally, I mentioned the continuous of care for the homeless. They have permanent supportive housing units. And Continuum of Care also have access to federal rental subsidies, that tenant-based rental subsidies that are specifically for people who are homeless. So these are some of your most important partners, and we'll be doing a deep dive into partners later on in this learning collaborative. And I think at this point, I'm going to hand it over to Ella.
All right, thank you, Robin. So at this point, I just wanted to, before we kind of ask you all to speak up about what else is top of mind for you, and we'll talk a little bit more about future learning community topics and any suggestions or thoughts you all have. I wanted to give a quick update on some policies that are happening at the federal level, and for those who are less familiar. So first, I wanted to talk a little bit about some efforts across HUD and HHS to align across health and housing partners. So the first is something that Elaine mentioned right at the top, the Housing and Services Partnership Accelerator, which is a technical assistance opportunity for states. And I believe that the states that were selected will be publicly announced in the next week or two. But also want to highlight this ongoing effort that they've had with the Housing and Services Resource Center, which is a website you can go to that has a lot of great resources, webinars with case examples, and other kinds of technical assistance resources that anyone can access. And so we have it linked here, and we'll be sending out the slides after this, so you can access that. And then I also want to acknowledge some of the recent guidance that's come out from CMS, or the Centers for Medicare and Medicaid Services, in November of 2023 and before that. So there is a new document that does a really great job of outlining coverage for HRSN services, which includes housing in Medicaid and CHIP. And I also want to acknowledge, along with this, some of the new excitement that's happening around newly approved 1115 waivers in several states. So I just want to highlight a few of the new things that have come out of these waivers. One key piece of this that there's a lot of excitement around is that now several states are able to cover short-term housing as a transitional service. There's also some states that are taking advantage of the waivers to do continuous eligibility for certain populations. Many states are doing this for the youth population in particular. One other piece is some states, I believe California and Washington, have approval, and many other states have proposed coverage of pre-release services for individuals who are exiting incarceration and re-entering communities. And also acknowledging that there are a lot of new benefits going into effect. Many of these waivers have additional funding for infrastructure so that states can make upfront investments in things like technology and capacity building among providers to really support effective use of these. And so targeted populations for these types of waivers definitely vary across states, but include many of the populations that Robin mentioned at the top, including adults and youth transitioning from institutional care, people who are experiencing or at risk of homelessness, and people with high cost, high need chronic health conditions or serious mental illnesses. Um, so while this is very exciting, there's still many questions about how, especially the short-term housing piece will be implemented on the ground. And really, CMS has emphasized how important it is for states to have partnerships for other state and local entities, including continuums of care and housing authorities that Robin just mentioned. So I also want to quickly just say that I talked a lot about the 1115 waivers, but there's many other Medicaid authorities that states can take advantage of to cover housing-related wraparound services for folks. This includes HCBS waivers and Money Follows the Person, and we'll be talking more about these in future calls. But I do want to highlight that under the Money Follows the Person program, or MFP, in 2022, CMS is announced that they're increasing the reimbursement rate for MFP supplemental services, so that now they're 100% federally funded with no state share. And CMS also expanded the definition of supplemental services to include some additional services, which it does also include short-term housing. So we did link to the guidance here, and there's some additional information about this that you all can look into, but we just wanted to highlight some of the exciting new things that are happening at the federal level. So I just covered a lot of information, and I know Robert and Elaine also covered a lot of great information. So I'll stop at this point and see if there's any questions before we move on.